limited countries improves. Next slide, please. Now, with this, our initiative was to focus. One of our initiatives is focused on improving quality of care, and using self-care. Using a self-care initiative, PharmAccess developed a self-care methodology which operates on 4 principles. The first principle is we should encourage a stepwise approach where facilities are encouraged to incrementally comply with standards of care. And the second principle is how do we measure improvements? We introduced standards for quality care which are internationally accredited, internationally recognized, and also with approval from the local authorities, Ministry of Health, and other partners. Then the third principle is that to accelerate improvements, we need information to know what are the challenges and how we can allocate resources to improve this, to address these challenges. And to do this, we need a timely availability of data, which is interactive and which can give insights at facility level. And the fourth principle is to ensure that there are structural changes to the health system which can impact outcomes and can be institutionalized. Next, please. Now, talking about this, the standards, we thought that the verticality of interventions which are common in most interventions is not the way to go. We should do a holistic approach, all areas where service is provided. The clinical services are provided and supporting services, how the housekeeping is done, how infection prevention control measures are integrated throughout the facility, and with this, it gives also opportunity for other interventions to work within this holistic approach. Next slide, please. Another important component of the self-care methodology is, and also to support them, engage on a daily basis to improve quality. We know that the healthcare workers would need to be motivated. We need to do, they want to get, if they are very far from the district offices, they need to get information. And we provided an online library which can support them to engage in quality improvement, to improve or to address the quality gaps which have been identified. And more than that, the platform would also help the workers those who are doing better to get like virtual badges to motivate them that, yeah, I'm doing well, and then I need to go to the next step. Again, next slide, please. The platforms also, the healthcare managers need also to have a timely information so that they can support healthcare workers to improve. The healthcare managers need to have insight at facility level, what is happening at facility level as they address their quality gaps. Who is addressing, who is not addressing, what are the challenges, what are the common challenges, and how can resources be focusing especially on those challenges which influence outcome of care. So, and this data should be, the information should be real, on real-time basis, and actionable. So, with this digital platform, we make the quality improvement process more interactive and also motivating to accelerate improvements. Next slide, please. Now, the self-care methodology has been applied globally in 21 countries. We started with 4 countries, but we have been spreading because it has been seen as being very useful and result-oriented, and we are now working in 3 continents, in India, in South America, and in Africa, and this, it gives self-care a global credence that this is a methodology that can bring changes to how quality is being addressed at facility level and in different countries. Next slide, please. I would like now to share specifically what we have been, how self-care methodology have been applied in Tanzania and what results we have achieved. From 2011, we have worked with stakeholders, Ministry of Health, private partners, and we have been able to work with more than 1,300 facilities. And most of these facilities are primary health facilities, majority of them dispensaries, but we have also covered hospitals and health centers in Zimbabwe. There are a lot of challenges in quality of health in Tanzania. You look at the performance, there's a lot of challenges in risk management. There's a lot of challenges in areas where would impact safety of the patient. There are a lot of challenges in areas which will influence outcome of care. And if we look at the profile of performance of these health facilities, we will note that majority of facilities, more than half, are at the lowest level of quality, where that the risk of care is very high. The processes and systems for care delivery are very high, and and only few facilities at higher level of care. If you look more, when you deep dive, we noted that majority of facilities, primary health facilities in Tanzania have at level 1, while as you go to higher level facility, as you go to hospitals, then you will see them moving to at least level 2 and 5 to 4. So, again, next slide, please. Looking at what are the gaps, what are the quality gaps in relation to potential harm to the patient, and also in relation to poor outcome of the service. We look at waste management, risk management plans, which have potential to influence safety of the patient. Performance is very low. Risk management, you have 88% non-compliance. Waste management, including infection prevention and control, you have 37% non-compliant. You have only 22% fully compliance with all standards of related to risk management. So here the patient comes to the hospital and there is a very high risk for potential harm. If you look more closely to in the areas where there's an unwarranted death, like emergency guidelines, resuscitation trainings, you'll find that there's a very, very low fully compliance. And if you relate this to neonatal deaths, if there is no proper resuscitation, the incidence of neonatal death may increase. So what you see is a lot of risk to patient harm and unwanted death. Next slide, please. So, with these findings, what are the key messages to you, to all of us? Please let us work together to bring down the preventable deaths and potential harm to patients. These are areas which we can address without adding much resources and reap the reward for the investments which have been made to improve access. Next slide, please. To achieve this, because as our results shows, and also other studies have seen, the problem is immense. I believe that no single organization can address it all. So, let us avoid fragmentations. Let us avoid fragmentations because the issue with fragmentation, we also waste resource and also we miss the chance of improving outcomes. Number two, again, the problem is immense. We need to accelerate improvements. Let us use the technology to improve efficiency and motivate healthcare workers to engage in improvements, because whatever we can do, the person who improves is the healthcare worker at facility level. We are just supporting. So let us motivate them to continuously engage. Let us provide, help them get information, knowledge online, and they can engage on improvements. And another call from us is, let us improve public-private partnerships so that we can address safety and improve better outcomes for the patients. The government is very important for regulatory, and the private partners also bring in more investments to improve quality. Next slide, please. And also to sustain any improvement which is being registered, it is very important that everyone is talking about quality. Let us embed the quality in the health system. Let us, from professional point of view, from health professional bodies, let us talk about quality. If it does not address quality, is like wastage of resources. If health insurance organizations pay for the services of members going to hospital and do not care about quality, is like wasting resources. So let us embed quality in the health system. And we also ask governments, public partners, and donors also. We should also be talking about quality. Next slide, please. And why should we do this? Why should we compelled to do all this? Because we know quality saves life. Thank you.
Again, members, another round of clapping our hands to a good work. Thank you very much. Now we are going to the next session of discussion with our seasoned panelists, and I will be introducing one to one, then they will be taking their seats. In our midst, we have Dr. Salim Slim. He's a director of preventive services and at the Ministry of Health, Zanzibar. He's a public health and a medical and a health scientist with strong background in immunology and vaccination, if I can round up. He has experience in low middle income countries as well as developed countries. To introduce to you the one who has just finished making a presentation on a success of safe care program. He's a director of safe care program at PharmAccess. Dr. Peter Risha is a pharmacist with a PhD in pharmaceutical science. And he has served in a quality of care area for more than 15 years again. So he's implementing and overseeing a standard-based model which was adopted by, we have seen more than 1,003 health facilities in Tanzania, and has worked also as a lecturer, senior lecturer at Muhimbili University College. He has more than 700 scientific papers citation. Dr. Peter Risha, please take your seat. We're also privileged to have Dr. David Isaiah. Dr. David Isaiah is a quality improvement coordinator at the Christian Social Service Commission. Has background in medicine, health economics, and financing. And is leading transformative changes and innovation at the CSSC. Dr. David is a holder of Doctor of Dental Surgery. He's a certified self-care assessor. He also serves a member of board members of number of various organizations. Dr. David Isaiah, please take your seat. And again, today we are really privileged to have Dr. Jenny Mary Rosie Manyahi, a medical specialist, obs and gyne. She's a medical officer in charge of Cardinal Rugambwa a faith-based organization, regional referral hospital level in Dar es Salaam. She has served as a district medical officer in Simanjiro, and they provided the leadership of quality improvement with a recordable success in that area, which enabled services to earn an international service level 5 from 1. So we invite her to come and share with us a vast experience she has accrued through leadership for providing services in Tanzania. Dr. Jenny Rosemary, karibu sana. I have my seat there, but I have decided to appoint it to Dr. Grace Magembe. Ukae pale, wewe panelist. Nitakupa kazi. Nimemteua amekataa. Amesema kwamba yeye atafanya portion yake, lakini anataka kukaa huku chini kuangalia. So thank you very much for accepting my appointment. She accept. Jamani, asanteni sana. She will give us a closure when we are closing this. We know Dr. Grace Magembe has served in a number of positions. Since when I met her for more than 20 years, she has served a medical practitioner, district medical officer, regional medical officer in Dar es Salaam, director of curative services, nikikosea utaniambia. She has served a deputy permanent secretary, PO large, then deputy PS, Minister of Health, and then back deputy PS, PO large for health. Am I right? So we are really privileged to have people who will share experience with us. Asante sana kukubali uteuzi wangu. So we have number of questions, and we start our question session now to our colleagues. And the first round of question goes to Dr. Salim. Dr. Salim, we understand you have really made a remarkable achievement in Zanzibar, making Zanzibar measles free. I think this is one of the remarkable achievement. And as we are discussing today, we want to move from quantity to quality with our expansion of health services. And we know that Zanzibar also have really embarked on strengthening primary healthcare services. What are you currently doing to ensure that quality and access are all integrated and addressed in healthcare system in Zanzibar?
Thank you very much, Mr. Moderator, and thank you, my panelist, but also colleague on the floor, for this opportunity. Obviously, over the last few years, Zanzibar has made a huge stride in transforming health system. Up to 2020, we did not have a district hospital. There was no district hospital. If someone in the community have any medical condition that cannot be taken care of at the primary healthcare level, it goes straight to referral, which really impaired a lot of pressure in terms of service delivery at the referral level. But His Excellency Dr. Hussein Al-Mwinyi, upon his chairing as the President of Zanzibar, he saw that and decided to put resources and making sure that each district among 11 districts of Zanzibar have their own district hospital, that making sure that all health issues are cared for where the people are living. That's very important. And that really has intending to reduce the number of patients that are attending referral. Prior to that, people could have probably just a wound seal problem and attending Nazimoja Hospital. Really, that's not how we define referral hospital in terms of its functionality. But those things that can now happening at the district level, at the primary healthcare level, allowing people who are specialists in the referral unit to deal with aspects that are assigned to their assignment. And that's one of the areas that had really improved quality to make sure that patients are where they need to be and getting the right care they need for where they are. But constructing this facility, which are brand new, has posed challenge, obviously. Yeah, we need to make sure it's not just a care that we render to the public. We make sure that they are actually given an adequate quality of care to ensure that we maximize the impact and outcome, but also we minimize adverse issues such as IPC in the facility and others. So in Zanzibar, we work in partnership. We work in partnership, especially in this area, with PharmAccess. PharmAccess has come and partnered with us, most importantly, first of all, to do a baseline assessment on where we are. And they went out there and then come back with measure and resolution and proposition that we need to make. So to impose that, then we start going to work. And we realize that there are some aspects at each and every facility at different level require attention, some of which we couldn't able to see them without this field visit or assessment that PharmAccess has done. Through this, we managed to create a match ending A before they go to B, but they are going to B before they go to C. And those guidelines were also part of work to make sure that it's well adequate and can be followed up. But furthermore to this, we also notice that approximately 52 facilities at the primary health care were not actually having adequate supply of water, which is very important element in relation to IPC. Because of that, we managed to intervene and resolve that problem. Now, we don't have any facility across Zanzibar that doesn't have good quality of water that provide for the patient. But furthermore, in terms of how we dispense and store our medicine, that was also an issue.
Thank you. I have been working with self-care for more than 10 years, so I really have a lot. We increased the scope, we engaged facility to improve quality. My frustration, many, but the key one is a very slow pace of improvement at facility level. We have tried so much, because one of the things when you go to a facility and ask, where is your improvement plan? And they'll take 10 minutes to look for it and it is not there. We adapted digitalization so that it can be available at all times to different people, but still you see some facilities improving and some facilities are not improving. And I think this is area we need a concerted effort, because we need to have all facilities improving and providing quality care. Thank you.
Next is Dr. Isaiah. Dr. David Isaiah, please. Now, I want to draw your experience. We know that FBOs are providing almost 40% of health system or health facilities network in Tanzania. And this is very, very significant and notable. And they would like to know exactly what importance are you putting in place and what strategies do you have to ensure that quality of care is all integrated in your healthcare system. And if you have any success which you have recorded, karibu sana, doctors.
Asante. First of all, at CSSC, we know that quality is important in all FBO health facilities. And if you can trace back, FBO facilities have been there since even before our independence. We have facilities, church facilities, which are there since 1980s. And they're still operating up to now. And they've been praised for offering quality services. But of recent, the quality has been deteriorating due to several factors, including there are so much depending on donors and sometimes government, and we face a lot of crisis in the West, in the wars in Ukraine and other issues. So the flow of funds has been a problem. So they are facing a lot of issues, one of them being quality. So at CSSC, we made sure that we put quality as the epicenter of everything that we do. Every project that comes to CSSC must have a component of quality. We negotiate with donors, we negotiate with whoever is supporting CSSC or facilities to make sure that quality is there. Whatever we do, we have to put quality as one of the initiative in a project. But also we first established the quality improvement unit, which was not there. So having a unit itself shows how serious we are in quality, and to have a coordinator, as I am the coordinator of quality. But also we operate in zones. CSSC, we have 5 zones. So in each zone we have one quality officer, full-time quality officer who deals with quality to make sure that we bring quality closer to our facilities, because facilities are distributed all over the country. So having the unity, having quality officers, that makes sure that we have brought quality closer to our facilities. But we do a lot. But we adopted safe care as an approach in quality, because before we just had some standards, different standards from different vertical programs, but we didn't have a specific approach that facilities can adopt. So we made sure that our facilities, those that we can reach, use safe care as the approach to improve quality in whatever they do. I think that's
any success, if you can jump on any success you have.
Yes, we have a lot of success. Most of our facilities are in rural. That's the church facilities are in rural. But we managed to have 5 facilities which attained safe care level 5. And those 5, only 2 are in town. The Cardinal Rugambwa, that Dr. Jenny is coming from, and St. Joseph in Moshi. But the rest, like Mugana, is in Misenyi district. We have St. Gaspar, Singida, Itigi, those, and Kibosho, which are in rural. So we have 5 safe care level facilities. We have more than 20 safe care level 4. We have safe care level 3. We have put a cut that our facilities should attain level 3 and above. If you are in level 2 or level 1, we consider you have a poor quality. So we have a benchmark, and each time of the year we announce the winners who have gained more points than others. So we have seen some improvement in most of our facilities.
Thank you. Thank you. I'll come back to you again. And now I invite Dr. Jane Rosemary. And in your case, we know that Cardinal Rugambwa at a regional referral level status, and you are providing all this leadership. And we have a question to you about your experience in attaining level 1, from level 1 to level 5. Can you please tell us a journey, your experience, a journey from, and what does it mean, by the way, for this audience really to understand, I mean, what is level 1, level 2, and how did you move to the peak where you are now?
Thank you very much, Mr. Moderator. As you said, we as a Kadurugamba Hospital, we started the journey of safe care standard in 2014. It took us like 10 years to attain level 5. In a standard care assessment, it has 13 elements, and these elements are assessed, and you have to pass in this all assessment with full compliance without failing the critical criteria. So it's when you get 84 and above marks without failing in any critical criteria is when you can attain level 5. So we started this journey in 2014 where we are at a level of district hospital. In the first assessment, we attained level 1, which was the lowest level. And they gave us a quality improvement plan. We worked on it, but we faced a lot of challenges, including financial issues and other challenges. And we had another 2 consecutive assessments where we attained level 4 again. So in 2023, we were enrolled in the PATA project through CCC and USA. In this PATA project, they gave us a lot of training and mentorship and supervision. So we put quality as our first priority. And through quality improvement plan, which we were given in the past assessment, we worked through it and tried to implement each activities. And these activities as a responsible person and time frame. And through this, we develop a quality improvement program, and we incorporate the quality improvement program in our organogram, and we hire a full-time quality improvement officer who help us a lot and make sure that these quality activities are doable in our facility. So other things we do as a part of management, we develop a lot of guidelines and update our standard procedure guidelines and a lot of policies which are supposed to be followed. And also we introduce clinical auditing system whereby we audited our activities on a quarterly basis and give back to the report to our staff. So doing so, we were able to attain to level 5. It was not a simple job, but it was a long journey with a lot of obstacles, but we made it. Thank you.
Dr. Apo, I was asking, what is level 5? If
level
somebody
5.
Yeah, you are saying now you are level 5. What is it really?
Level 5,
just explain a bit.
Level 5 is the highest standard of safe care standard. It's the last or the highest standard of safe care level 5. It means that the facility is providing a quality and safe care to the patient, which meets the standards, the international standard, which are set by the safe care standards.
Okay, thank you. Now we are going to the second round of our question, and please give mic to Dr. Slim. Dr. Slim, want to look at innovation. What innovation are you putting in place, especially on data management, digital system? How useful is it? If you can share your experience.
Thank you very much.
2 minutes, please.
Yeah, perfect. Thank you. Again, our government has provided a special card that has got patient data in it with barcode, like QR code. And that was under sponsorship of PharmAccess as well. We managed to give this to every patient. So in every visit, when the patient visits any facility in Zanzibar, they scan that patient card, and that will provide all information about the patient, their last visit, and much detail about that patient can be revealed right there. right? So if that patient has received, say, medication, XYZ, and then they come there and say they didn't have that medication, for example, we will say them, no, you receive them. But previous to that, we could have patient visiting facility A, get prescription, and take medication, and go to facility B, take the same drugs. We can't really track them. Yeah, that was very costly for the government, and we couldn't monitor our drugs are stocked properly. But because we have those quality information that allow us to track about patient information, it has become much easier for us to know our patient even in much deeper level than the way they are. So doing that can also tell us about disease in some area. For example, through that we managed to find out that across anemia in Zanzibar, majority of anemia are situated in North Unguja and Pemba. This is because of the data that were collected. The hospital data that we collected tell us we have high prevalence of anemia in Zanzibar, but the prevalence or epicenter of those issues are actually in Northern Unguja and Northern Pemba. When before we utilize unified intervention, so we could go everywhere and intervene about anemia. But right now, we put resources for anemia where the issue of anemia is actually prevalence. So that really helps us to really allocate our budget in the right place, allocate the right intervention in the right place, and improve the impact of that places with minimum resources.
Thank you, Dr. Sai. We are seeing that you get really data and you plan, and thank you for that. I think this is one of significant achievement for the program. And Dr. Peter, again, can you tell us a bit on investment required to make this success in 2 minutes, please?
I think we need a lot of investments, and at the same time we may not need much, because if you look at data, what is the major cause of poor quality services? The data from the World Bank WHO study and our observations during the 10 years, the major cause is not complying with guidelines, not complying with best practices which are approved for care delivery. And then if this is the case, if this is the major cause, then how much resources are required to ask healthcare workers to follow guidelines? Maybe we don't need to add more resources, but how do we change the way we work? How do we ask people to do what is known to be right? Thank you.
Thank you, Dr. Peter. Very concise and brief. Now again, Dr. David Isaiah, you have marked a significant improvement, and it is known that from our reports that we have the largest of the facilities which has attained level 5, the highest level. Now I want to draw your experience on how did you use your targeted coaching, mentoring, and clinical audit in this process to make sure that clinical and the quality of care are provided at a go. Most welcome.
Thank you very much. First of all, we all know that quality is all about attitude. And if people have the wrong attitude, they cannot improve. And but at CSNC we have adopted the Maxwell says that everything rises and falls in leadership. So we knew if the leaders have the right attitude, they can impact the rest of they can impact the management, they can impact the facility and the like. So we started with to find the buying from the leaders. And you know, most of the owners, they are the bishops. So you have to make your message as simple as possible for the bishop to understand what you want to do in their facility and what is quality. So we explained to the bishop, when we got the buy-in of the leaders, we went to the management, we trained the management on quality, we made sure that they also adopt some of the issues we discussed with them, like what Dr. Jenny said, that they have to have the full-time, as a hospital, have a full-time quality officer in the hospital. As soon we know the number of staff is very, very low, but for a facility to appoint one person to deal with quality from morning to evening, the moment he enters the facility and he leaves the facility, that is a sacrifice they have to do. So the management agreed to that, and also the quality improvement chairperson has been incorporated in the hospital management team. And they agreed also, is among the department leaders, he led the department of quality. So this is what we do with the management. But also, we found most of their plans, they don't have budget for quality activities. So we started with the strategic plans. We helped them to develop their strategic plans, but we made sure that in one of the objectives in the strategic plan, talks about quality. So if it is in the strategic plan, it means going to be reflected in the annual plan. So the annual plan also has quality activities which are budgeted, so it will be easy for them to implement. So when they started the quality journey, we provided quarterly support. Our members, our quality officers visited them on quarterly basis, and they together solve the challenges that they face in implementing quality activities. But also, as I said earlier, we reward best performers. Each year we have the Tanzania Christian Medical Association meeting. For those who get, previously we were awarding even the level 4s with the highest mark. We give them a certificate, but later for those who got level 5, we announce them there. We print a big certificate. They are given by the guest of honor. They are announced. So people started to ask, how did they do? Because people knew that it is impossible to attain safe care level 5. So when they see others are attaining and they're rewarded in front of others, they started to ask. We have a facility that when it was announced, they went to another facility that got level 5. They asked who is the person behind this. They hired that quality officer. They paid twice the salary. They took him to another hospital. So it was a problem to this facility, but also implemented, and they actually in the next year they got safe care level 5.
Thank you. I know you have a lot to talk for and you have audience, they have question, we have closure, so I want really to maintain the 10 minutes for the audience question and the 5 minutes for Dr. Grace closure. Now coming to you, Dr. Jenny Rosemary. We know if you are looking at this, it's like you start with a team. It is not static. People move in, people move out. I mean, how do you manage this? Changes of personnel in managing and ensuring that quality of care is maintained and sustained.
Thank you very much for the question. As Dr. Isaiah said, we had a lot of training to the management and to the other staffs on the board, but this training are ongoing training. We keep on training the new ones so that they can adopt the safe care standards and live with it. Also, this quality agenda was incorporated in our strategic plan, 5-year strategic plan. So every year you have to implement. It's one of our key performance indicator. So as a leader, even if he's a new leader, he has or she has to implement that, the issue of quality as a key performance indicator. So it is measured. And through that, we keep on, and we trust that we will continue living in the standards which we set.
Dr. Rosemary, again, this discussion is a process. But can you tell us any notable outcome we are seeing in patients? We said it should be human-centered. What are we seeing as a result of this process for your case? 1 minute.
For our case, it is a success story because while we were at level 5, we were scrambled with also financial issues. We could not run the hospital. We could not pay salaries for maybe 2 to 3 months because number of patients was decreasing. But when we started this program of quality improvement and the safe care standards, number of patients keep on increasing, and up to now, we are able to pay salaries, to do motivation to our staffs. Also, we maintain the standard of care. And also, as a gynecologist, we had issues of maternal death and newborn death. But through this improvement of quality, we reduced the number of maternal death. And last year, we had only one death in the facility. So it's a great achievement to the care of the patient and to the sustainability of the facility. Thank you.
Thank you very much. Thank you very much. Yamani, another last round of applause to this team. Now I want to invite members here, participants. If you have question or you have comments and the recommendation, we have like 7 minutes. And it will be very... Dr. Kamugisha will give you, but you need to be brief today. I start with the President. President Kamugisha.
I am that president of Small ARA from the Medical Association of Tanzania. Yeah, my name is Mugisha. I'm coming from Benjamin Mkapa Hospital and Medical Association of Tanzania. I'll be brief. We understand quality is beyond accreditation. We have 6 metrics that we need to look at. We have safety, we have efficiency, we have effectiveness, equitable, timely, and patient-centered. I understand we have a global action plan, but we are not doing very much within our country. I'm calling upon all partners to look at this because we know 4 people out of 10 are getting harmed at the facilities that are even accredited. We do not have data in this part of the world. So this is a very big number. Number 2, when you're looking at patient safety, we need to look at the culture of quality improvement and patient safety. Most of the time, we are really emphasizing on policing. Umefanya hivi, then you need to act like this, we need to reprimand you this way and that way. And that has really confused the metrics of incidence reporting. Our incidence reporting on harms in the hospitals is very low and no one is tracking it. Last but not least, in terms of surgery, our facilities, I've seen from your data, only 40% are utilizing the WHO surgical safety checklist. Theater and operating rooms are most dangerous places. And if we do not observe to this tool that have been developed by WHO, we won't be able to address the complication rates and peri-operative mortalities that are affecting our people. In Tanzania, ukiambiwa nenda ukafanyia operation, patient will say, subiri kwanza niende nyumbani nikaongee na ndugu. Actually, when he goes home, he's not talking about should I take surgery or should I not take surgery. It is the conversation, who shall inherit all of my belongings if I die in the operating rooms? And once he has sorted that, he comes to the hospital comfortably after sorting all the family issues. So we need to look at patient engagement. Lastly, we mark September 17 as World Patient Safety Day. In Tanzania is less marked. I call upon all of you to participate in marking that particular day. We need to involve our patient in decision making and requiring quality. Wagonjwa wetu wafike mahala wawezeshwe kuuliza daktari, umenawa mikono kabla ya kuniona? That is IPC. Daktari, umeshaandaa damu kabla ya operation yangu? That is involved in transfusion. Na mwisho kabisa, nawashukuru sana kwa kunipa nafasi.
Thank you, Dr. Mugisha. Dr. Mugisha is the president of Tanzania Medical Association. He's asante sana. Thank you for remarks. And now I'm just looking if there's a lady in our. Yes, there's one here. Please, 1 minute.
Thank you very much. This is another president with a small R as well. President of the alumni of MUHAS. Thank you. I'm here to also echo what the other small R said, aiming at 0 accidents and of course 0 infections. So when we look into this, I'm seeing also the patient-centeredness, people-centeredness in a way. But again, connecting with the 17 SDGs where there are 5 Ps, people, how are we very much doing with planet? Because when we are working on a lot of quality improvement at facility level, we tend also to forget the planet, where we are saying we only have one planet and this planet is only Earth. Can you also share around those areas? Thank you very much.
Thank you very much. I think with interest of time, this is very exciting, very important, and let's see if I will be given another 5 minutes, but 10 minutes. I'm told that I have 10 minutes. Thank you. There's a donation of 5 minutes. You know that I'm looking at you. You raise your hand? Yes.
I'll break the trend. I'm not a president of anything. But my name is Kelsey. I'm from Touch Health. I'm a project manager for M-Mama. I'm also a critical care nurse. And I wanted to ask you guys a little bit about your thoughts around involving nurses in quality improvement efforts. I think we talk a lot, especially in Tanzania, there seems to be a lot more leadership from the physician community, but nurses often serve as the last line of defense if a physician has, for example, broken sterile field in an operating room, or a pharmacist has filled the wrong amount of a medication. Nurses can be that last line of defense. So where do you see the role of nurses in Tanzania in quality improvement, and how are you involving them in safe care? Thank you.
Okay, thank you. The following question, would like to know where are you addressing that to make sure that it is dropped to. I know that she will reprimand me. Doctor, you are most welcome. I know you have something to say.
Okay, thank you so much. Thank you for the panelists for the nice presentation of the issue of the quality. My question is, do you think at this stage now, because we have been talking about quality, but we are not attaining the standard we want. So do you think at this level now, healthcare facilities, level of delivery healthcare system should be correlated with the quality of care? What I mean is like we have dispensary, we have health centers, we have district hospital, we have regional, national, and wherever. So can we think about using the quality standards to give the facility level of care?
Okay, thank you. Now I want to give 1 minute for my esteemed panelists. There was a question on our Mother Earth. I think she was talking about climate change and those related to SDGs. If you have, and I want to give this specifically to Dr. Salim. Do you have anything? A minute, please. That she's not seeing it given a space.
Yeah, I think I will talk about this in the Zanzibar context. Over 3 years that I've been a director of the preventive service, I've seen a huge stride in how we really offer or render care to our public. And that was from availability of 10% of medicine that are essential to 97% of the medicine that are essential, from IPC level 0 to IPC level 3, right? These are, and other are still level 5, to having no facility at the district level where patient come from primary health care straight up to the referral hospital for the medical attention that probably would have been resolved at the district level. These come at cost, right? These come at cost, and obviously there are some amendment that we have to continue to thrive on making, but based on the being climate friendly, if that's a question you're posing, obviously we take everything into consideration when we make those decisions. We still have, I admit that we still have, and we continue to use chemical in cleaning our facility that probably are not environmental friendly. Yeah, we probably will have loved to have the best alternative, right? And that's definitely something that we as a government need to consider, and we take that on board. But like I say, this is a job in progress, and everything that we do, we try our best to make sure we serve our people, but also try to balance well with environmental destruction. So we will make sure we take that on board, and when necessary, we will assign ourselves to make sure whatever we use in a facility is more likely to be environmental friendly. So thank you.
Dr. Salim, asante sana. Thank you very much. It is exciting. In fact, this is quality of care is an agenda of a day, and it should be part and a parcel of our policies. All discussion, development, as we transition to new strategies, vision, let us make sure that quality of care is really maintained. I want to thank you for being privileged to moderate this important session. Now, I invite Dr. Grace, as I said before, to give us a closing remarks and any wisdom she has on that. Karibu sana, Dr. Grace.
Yeah, good afternoon, everyone. Thank you, Dr. Daddy, for hijacking me, because you did not invite me before. So if I do it right, give me all the credit, but if there's anything wrong, it should go to Daddy. He did not prepare me at all. But again, I want to thank all our panelists. You did a great job. That was a very good discussion. And as well as to the audience. I could see there were more hands that they wanted to ask questions, but the time wasn't enough. So quality is a very broad agenda. I was listening to all the questions here, to the issues that were raised. If you talk to a surgeon, he'll talk about quality in the theater, about his patient, you know, how he operates, etc., etc. But if I call a community health worker here, he will not talk about that. That will not be his or her concern. There will be something else about the community that to him or her is defined as quality. My sister here, another president with a small R, she talked about the environment, climate change. That is also quality. But if you call a radiologist here, you call a lab technician here, everybody will have their own perspective on what they define as quality. So quality is not a simple agenda. And that takes me to something else, Daddy. We've had a number of initiatives in this country on quality improvement. They are all tailor-made to specific interventions, to specific projects, to specific issues. But do we have what we define as quality in this country? If I ask you, Daddy, to stand up here and tell me, what is the definition of quality of care? Quality of health care in this country? I'm sure you won't be able to tell me, because there are so many patchy interventions. So to me, well, I moved from the Ministry of Health recently, which is the ministry that was responsible for setting policies, guidelines and stuff. But I'm still there, because even with the PRH, I'm still responsible for health. So to me, Daddy, what I recommend from this session, from this forum, to the bigger forum, to the recommendations of THS, and the good thing I'm a member of the board of THS, let us have one deliberation that it's high time now we come up with what we call, with a recommendation on what this country is going to define the quality of healthcare. If we do not do that, we'll keep on coming to these meetings every now and then, and we'll never really have something that we really define as quality. Yes, it's a big agenda, but let us agree as a country, the government together with our partners, that this is where we're going to start. Let's start with this and probably continue improving on what we have. But right now, we are talking of so many things and we end up confusing our staff on the ground. To me, that is not proper. I and you should sit down as, do we have learned brothers and sisters in the medical field? I don't know whether it's only lawyers or us also, and define what exactly we want. But quality is something that should be measured. Okay? Once you have defined what you want, and you have defined how you're going to measure it, then you plan how you're going to improve it. So those three issues are very important, and I like the title or the slogan, Institutionalizing Quality Improvement. Because right now we have so many, everybody, they're working in their own direction. I know that the Minister of Health is here, and we've been discussing on having a body. Yeah? So I think that's the right direction. And probably all this mandate will be under this body. Because if you ask me, Grace, I'm a healthcare provider, I'm in the policy side, and I can't also be doing, assessing quality because it's a conflict to me. So probably let us have that deliberation from this meeting, that now probably we need a body that is going to be responsible for this. Accreditation is part of reaching where we want. We can't leave it out of this question. But I like the presenters. They talked about quality is not a one-man show. It's not for the government, it's not for the partner, or it's not only one person in a facility or wherever. Okay? Quality, you need people actually who know what they want to happen to provide that quality of care. You need people who have the right skills to make that happen. If you do not have those people who know what they want and how it's going to happen, you can't talk about quality. But again, quality, it's not a one-day event, okay? Quality is a commitment that we make over time. It's a continuous process. When my brother Risha was presenting here, I don't know, that is, those were findings that happened in one of the intervention previously. But things have changed. By then, we did not have infrastructure, we've improved infrastructure. We did not have equipment, we've improved equipment. So I think it's high time now we assess ourselves, because this is a continuous process. It's high time now we assess ourselves. After all the investment that has been done in various aspects of health, what is missing now? What is the next step that now we should be taking? So Risha, me and you need to work on that, yeah? Because the findings that we're presenting, I agree with them, but there has been a lot of developments, recently. So I think we need to sit down and again assess ourselves, see exactly what we want. So Dr. I think it's Isaiah, he talked about leadership. I agree. You can have all the resources, but if you lack leadership, it is as good as zero. And I want to add something else. Quality is about making it part of the culture of the organization. It has to be an integral part of the organization. If it is not, you can have all the resources and it will never happen. So I think the task ahead of us, and that's why probably quality has been really a hard bone, not only to the government but also to the partners, because it takes time to change people's attitudes, to change people's culture, the way they look at things, the way they perceive things. Okay, so we should know this, and that's why it is a continuous process. The more we do it over and over and over and over, it sinks. But our sector, some people retire, some people die, some people leave the sector for so many other reasons. What is the plan of making sure that this becomes continuous. We replenish those skills that are lost for any other reason. So that also has to be part of what we are discussing. You can't do it in one time and then you're like, I'm done. You're not done. You need to keep reminding people, but also you need to take into consideration those that are leaving the sector for any other reason. So if you talk of quality improvement, of course, you have your inputs, you have your processes in place, you have your outputs, and then you have your impacts, etc., etc., etc. And I must recommend all of us here, because even the government has not reached where we are, we as ourselves, it is our work. If you look at the inputs, a lot has been done. If you look at the processes, a lot has been done. So that's why I said we need to reassess ourselves and see what is missing now. What part of the puzzle is missing so that we can fill it up. But really a lot has been done. If you look at the health sector 20, 15 years ago, it wasn't looking the way it looks today. So I urge you, all of us, let this come as a deliberation from this meeting. And on our side as a government, we are ready to take it up and see really how best we can move forward this agenda. Quality is not only satisfying the client, it's also satisfying the provider. That is part of quality. The provider has to be satisfied. The client has to be satisfied. So if you look at our quality interventions in the past, Daddy, they were more skewed to satisfying the client. What about the provider? If the provider is not happy, where will you get that quality from the client? So I think it's high time now to look at how we are going to balance both, okay? How we are going to balance both, the provider as well as the client. But again, we need a very strong component of monitoring and evaluation, because we have a lot of interventions that we are putting in place. We need to find out whether they are working or they are not working. And we shouldn't forget research and development. So you asked me to speak, Daddy. I wasn't prepared, but you just told me to speak what I can speak. And this is my mind speaking. You're welcome. Let us sit together and see how best we are going to address the issue of quality. It's very wide. It's very important. After all the investment that has been done, the biggest puzzle that is missing is quality. Thank you.